Hi everyone, welcome back to the afternoon. Hope you all had a nice lunch and have used the opportunity to do lots of networking. So my name is Claire Liu and I am the Nursing and AHP lead on the Breast Pathway Board, and my co-chairperson for this session is Claire Robinson. So as part of my role, I have been trying to re-establish the Nursing Forum. So I'd like to just thank anybody who's been involved in that for your help in doing that. And I've also been enjoying going around the units, trying to introduce myself. I'm a great believer that we are stronger as a force, so want to encourage those ties amongst us as much as possible. So we've got a nice power hour to keep you awake after the lunchtime feed. So I'm going to pass you over now to, first of all, I'd like to introduce Jo Taylor, who's sat at the back. She's not going to come up and speak today, but she is one of the patient representatives on the board, but also a founder of MetUp UK. And I'm going to introduce Kat Southwell from MetUp UK as a patient advocate.
Hi everyone. I'm not a patient of the Greater Manchester Cancer Alliance. I should probably just give that as a caveat. So I am a patient advocate for MetUp UK, which is a metastatic breast cancer charity. I work with Jo Taylor, and we seek to improve outcomes for patients with metastatic breast cancer across access to trials, drugs, and improving quality of data. So it's a bit of a rude title to say why bother with our own clinical trial listing. But the reason why we do it, and we get asked this a lot by clinicians, is that access to clinical trial information for metastatic trials for patients is really poor within the UK. There are a number of listings that are out there that patients can use. So generally, patients are directed to Cancer Research UK and be part of research. And there are also commercial tools out there as well, such as Encora. But all of them suffer from the same issue, which is poor data going into them. And if you have poor data in, you get poor data out, as we know. So since 2018, MetUp have been producing a metastatic clinical trial listing that's for the whole of the UK. And it's quite a laborious task for volunteers to do. We don't get paid for it, and we do it every single month. And recently, we've turned it into a dashboard, so an interactive dashboard based on a map of the UK. And what was interesting to us and to a number of clinicians is that actually it started to show the data in a slightly different way. So not only could we see where there were trials, but suddenly we were seeing where there weren't trials as well. One of our key aims that we have as a charity is to encourage metastatic breast cancer patients to get onto trials earlier and think about them earlier. So I think there's a bit of a historical feeling amongst patients that you do your treatment lines and you work through them, and then when you get to the end and there isn't a treatment line left, then you do a clinical trial. And the problem is that often you are too poorly by that point to get onto a clinical trial. So our cleverest patient advocates that we have are the ones who do a treatment line, then they do a clinical trial, then they might do another clinical trial, then they might do another treatment line, and they can stretch out that metastatic pathway to a significant amount of time. One of our former trustees, who sadly now died, managed to do 10 years through intertwining clinical trials in between her treatment lines all the way through her 20s. She was diagnosed very early with breast cancer. So that's the reason why we do it, is that the data that's out there isn't good, and we want to encourage patients to start thinking about trials much earlier. There's some research, I don't think it's been published quite yet, but it is about to be published by Carlo Palmieri and the charity Make Seconds Count with regard to access to clinical trials and patients being talked to about trials. And they found that only 23% of metastatic breast cancer trials had been spoken to about trials. Sorry, metastatic patients have been spoken to about trials by their teams. So, in the interest of keeping to my time slot, we have timed this video very accurately, but whether I can keep up with the words at the same time will remain to be seen. So let me just work out how I need to do the play. And hopefully it should start to move around whilst I speak. If the video is working. Yes, I can see things are starting to happen. So the dashboard was designed so that patients can interact with it by location and by trial type without the confines of where they live, because obviously they can go and stay with friends, they can go and stay with family, they might have access to money, means, travel, etc. to be able to go further afield to get a trial that they need. As you would expect, there's a greater amount of metastatic breast cancer trials in the locations where there are the experimental cancer medicine centres across the UK. So the notes that I should say with regard to our listing is that we focus on interventional trials that are actively recruiting, and we split that between targeted metastatic breast cancer trials and solid tumour stroke basket study trials. But if we have a solid tumour trial where there might be a cohort that's specifically for a subtype of breast cancer, we will actually call that a targeted metastatic breast cancer trial. So what surprised us in this data? Well, number one was Birmingham. When we first launched this, we thought there must be something fundamentally wrong with our data. And we actually reproduced all of the data again because we couldn't believe that there were no metastatic breast cancer trials recruiting in Birmingham. And that was back in June, and it's been the same ever since. So on their website, they have 17 primary breast cancer trials recruiting at the moment, but they don't have any for metastatic breast cancer. And yet they are the third largest city in the UK. I accidentally said at a previous conference in Manchester earlier in the summer that they were the second largest city, and I got a big boo, so I've corrected that in my understanding. They are a very large cancer alliance, though, I would say. Joe and I have just organised a metastatic breast cancer conference for Wales, and we did that last week, I think it was. And the Birmingham aspect was a big concern for patients there, because for those of them who are living in mid-Wales, Birmingham would be the place that they would go to for trials. So Truro, I'm running a bit behind with the video, I'll go quicker. That was the other strange anomaly, but in the opposite way. So we had lots of metastatic breast cancer trials recruiting for a relatively tiny part of the UK. So much so that it has more trials running for metastatic breast cancer than most large cities in the UK. We now know, because someone's told us, that this is to do with a guy who loves surfing, and he moved to Cornwall during the pandemic, and so the love of research has gone with him. We sort of chuckle and we see that as a light-hearted thing, but actually to show that just one tiny change from one individual can make a significant aspect of survival for patients shows how fragile our clinical trial sites are. I will come on to Truro later because there's something interesting. So Northern Ireland is another area. I'm really behind the video now because I'm on to Manchester. Things are bad in Northern Ireland. We have a team who work over there, and there are very few clinical trials running, and that landscape doesn't look to change anytime soon, sadly. So on to Manchester. So we think that there are about 35 trials in total. 24 of them are targeted metastatic breast cancer trials, and there are 10 for solid tumours on our listing. Now, Sasha was kind enough to give us the exact listing for Manchester so that we could put together whether us scouring lots of public available listings was as good as what the reality of the data is. And it's not bad, I have to say. So where our differences come in, we had all of the trials that are recruiting in Manchester. So that was a good thing in terms of what patients have access to. Where we differ is where we think that trials are still recruiting, and obviously they've now closed. And also where we think trials aren't yet recruiting because they're not on public sites, but actually they are recruiting internally. So there are two main differences that we have within them. Interestingly, if I'd have used Be Part of Research, which is the tool that patients are told to use by everybody across the UK, they're told by the NHS to use it and the government, the first result I would have got for Manchester would have been the Ad Aspirin trial for primary patients, because someone helpfully put in the title of the Ad Aspirin trial, non-metastatic. And so what happens is it comes up in your search history. And this is the problem that we have with all of our data about clinical trials that exist on public tools out there, is that they are not clever enough to refine data in a correct way, to understand the difference between a trial that's put in non-metastatic in the title with it actually being metastatic. So when you're searching, these are coming up to it. Interestingly, the second trial on Be Part of Research for Manchester is actually not recruiting in Manchester, so you can kind of stop looking and you get the gist of it at that point in time. So that's our interactive dashboard. What we've learned since launching it is that although techies like me are okay with that kind of thing, actually for most people, they want to just go to where are the triple negative trials, where are the HER2 positive trials. So we've built a triple negative dashboard that's specifically for those patients. And the next things we'll be doing is putting in one for hormone positive and for HER2 positive as well. Now I need to get off of playing the video. So I have to switch to notes because it all gets a bit data geeky. So if you're a breast cancer patient, the main charity for breast cancer is Breast Cancer Now. They don't do a clinical trial listing. They don't give any information about clinical trials. That's quite at odds with a lot of other cancers, I have to say, where the main charity will provide a clinical trial listing. Target Ovarian Cancer does it and does it very well. They have good quality trial data. So what patients are told to use in the breast cancer community are Cancer Research UK and Be Part of Research, and they only have a tiny piece of the story, as I said earlier. Cancer Research UK, if you were looking for metastatic breast cancer trials on there, you cannot get to them. You have to read through a list of breast cancer trials and then work out which ones are metastatic. Now, a lot of patients wouldn't be able to do that, so it's not very helpful. Interestingly, they have a filter for secondary cancers, but only by location. So you have to go secondary by bone, secondary by liver, secondary by brain, which isn't necessarily the way a patient would look for it. Even when you comb through, there's only actually 11 that are listed on there. So Be Part of Research. Going back to our Truro example from earlier, if I look at Truro, you have to use the word metastatic in Be Part of Research. So we were just talking about this before I came on stage about do we use the term secondary with patients or do we use the term metastatic? If I put in the term secondary breast cancer into Be Part of Research, I get one trial in Truro, and actually it's not for secondary breast cancer. I don't know why it comes up in the search. But if I put in metastatic breast cancer, that's when it gives me a list. It's not a correct list, but it gives me a list and covers the ones that were included. So that language between metastatic and secondary is really important, and people who are putting together clinical trial listings need to think about that, because if we want to talk to patients about being secondary, and then they don't find trials, we've got a problem there in the language that we use. Sorry, I'm just piecing my brain cells together. So the other challenges that we have with the data coming up, which exists in clinicaltrials.gov as well, and some of the other listings, is where people will use short terms in clinical trial information. So for example, mTNBC will be used a lot for metastatic triple negative breast cancer. But if it's never spelt out in a full word somewhere, those trials will not come back in any search criteria. So you need to know that that's what it is. I mentioned Ancora at the beginning, and just to say that I am slightly better as a human than what that system can do. So whilst I would love to be able to put my feet up and let AI take control and find all the clinical trials for me, the human is still a little bit better to be able to do it. The other thing that Be Part of Research doesn't do is it doesn't always include the short names, the fun names like blush, in their trial listings. So if as an oncologist or as a nurse you said to a patient, go and have a look at the blush trial, if you went to Be Part of Research, you may not actually get it, because if they haven't put the word blush in, it won't actually come up within the trial listings. It's not for all of their listings, unhelpfully, it's just some. So some will have the short name and some won't have the name in at all. So for us, everywhere we turn, we're let down by data. So what we're pulling together, we know is incorrect. We know our dashboard is not right. It's never right. Every single month, it's never right, because we aren't based within research trial units and we don't know exactly the latest up-to-date recruitment information. But it's an over-calculation, and I think that's important to say, that at worst, it would mean that a patient comes to you thinking there might be 3 trials, when actually there might only be 1, or they might have just missed out on something. But that's the worst it can possibly be, is an over-calculation of the number of trials. What we fail to get to in all of this is who's actually accountable for the better data, and that's where we really struggle as a charity. What we're trying to do is to work with the people who are responsible for the data to try and make it better, but until such time, we as volunteers, as people with metastatic breast cancer, with side effects from all our treatments, have to slog away every month to make sure that we've got this for our patients. Thank you.
Thank you, Kat. That was really interesting. So our next speaker is Rachel Pastor, who's a clinical nurse specialist from North Manchester, and she's going to talk to you about metastatic breast cancer pathway at North Manchester General. Thank you, Rachel.
I'm told this is easy to use. Apologise. Okay, yay. Yeah, also not the week to try and lose your voice when you come in to speak here. So bear with me. Claire's got water just in case. So, as Claire said, I work at North Manchester. We see primary breast cancer patients. However, we also continue to see secondary breast cancer patients. So we realised there was a gap in the system and things needed to change. So we had the introduction of personalised care, or as we all used to know it as treatment summaries for all our adjuvant patients, and this only made the gap in the provision of care more noticeable. Treatment summary, or personalised care, actively identifies and addresses the unmet needs of the patient and ensures they are fully informed and supported. However, there didn't appear to be anything equivalent in the secondary breast cancer setting. And I know, Jo, we've had discussions in the past quite often about that not being the case. And I've also been in meetings with the girls at the Christie who have been incredibly supportive, and I do need to say thank you for their help in the development of this clinic. So what to do? So as nurses, we decided to set up our own clinic. A few years ago, I worked on this with a colleague who's no longer working with us but works at Wythenshawe now. And this was kind of like our baby at the time, and we spent a lot of work getting this set up. Unfortunately, she left to go, actually retired at the time, and she's come back from retirement. And then COVID happened, so it unfortunately stopped the start a little bit. But we're back on track now, and hopefully this is more what it's going to look like. So at the moment, the patients will get a designated appointment with the CNS. That can be face-to-face if the patient wants to come in, or if they're too unwell or don't want to, we can do it over the phone. And only recently, I have managed to do a couple of home visits where there was no other option, which the patients have found beneficial. We offer a holistic needs assessment. It's a little bit different to the ones you might notice in treatment summaries. With Colette, who works in the personalised care, we have got a slightly more slimmed down version of the HNA, which seems a little bit easier for our secondary breast cancer patients, or metastatic breast cancer patients, sorry, Kat, to actually go through, and there's not quite as many questions. So that's I've got a copy with me if anybody wants to see it. It's more than possible to share. We highlight the concerns the same, and those are discussed. If we can deal with them there and then, we try and do that. However, often that involves referrals and signposting on. We're really lucky up at Oldham, which is our other site, so we're at North Manchester and Oldham. We're really lucky at Oldham because right across the car park, which is not massive, from the Victoria unit where we work, we've got the Maggie's Centre. And that's a fantastic resource for all our patients, so often a lot of signposting goes there. We've also got the Macmillan Information Centres. We've actually got one at Oldham, we've got one at North Manchester, and we have access to the Christie one at the Christie at Oldham as well. So we are well supported from an information point of view. We could always discuss the current treatment plan, always being aware that that is different to a treatment summary, whereas in our metastatic breast cancer patients, that treatment plan will change. We can only discuss what's going on at that moment, about where they're up to and what possible signs, side effects, symptoms, things that are going on. And so far, what we've found by talking to patients is that they actually feel more comfortable discussing that with us as nurses, rather than sometimes with either our surgical or oncology colleagues. Not that they don't want to talk about it, but some of them have actually said they worry if they show too many side effects that might change or stop their treatment. We also talk about who to contact with what, because I did a project back with GM quite a while ago, and we had patient representatives on that. And the one thing that a lot of them said they found really difficult was that these patients are often under multiple sites. So they might be under us, they might be under the Christie, they might be under Salford if they've got spinal problems. There's multiple people involved, and they found two things really difficult, which was who to contact with what, so who's dealing with which appointment, and other than that, having to repeat the story every time. So they'd go to an appointment with somebody else and it'd be like, start again. So what we're trying to do, it is a work in progress, is have something that they can actually take with them. So it'll have it on where they're up to at the moment, and they can actually take it to that next appointment. Because unfortunately, us and Wythenshawe are quite lucky in the moment that we can share a system, but not other systems are on board. So we can't share with NCA, where we are at Oldham. We can't share with the Christie. So at the moment, not always those letters are easily available. So it is the patient that's telling the story all over again. Challenges, because nothing happens without a challenge. So the biggest challenges that we found are what I've put there really, which is when. When do we offer that appointment? However, that leads into the next one, which kind of go together, which is identification of the patient. So as I said earlier, we cover the surgical clinics, we also cover the oncology clinics. Those patients who are metastatic can turn up in any of those clinics. It doesn't matter what they've come for initially. You could have somebody in a one-stop clinic who actually then becomes metastatic at diagnosis. We're not always in every clinic. Our staffing doesn't allow it. So how do we find those patients? The only things we've come up with so far, this simplest one at the moment, is through MDT, because that's where it's usually identified. So whichever poor breast care nurse has got the job of being on our MDT, which Miss Abbas, who's here today, will tell you is extremely long, will have something with her and just put in a star or something at the side of a name to say, you need to pick that one up. The other thing, I'm sure Joe will agree with me on this, is the other thing with metastatic patients is actually knowing how many they are is virtually impossible. The information just isn't there. The girls at the Christie can tell us who they're looking after because they only deal with their metastatic patients. But for those of us that do both, we just haven't got the lists of these patients. So we're keeping our own information for that as well. Staffing levels obviously change. We lost quite a few of our breast care nurses to retirement, fair enough. And now, thankfully, we've got a whole new influx of new breast care nurses. We've gained 3 at least. So hopefully that won't be a problem. The other thing that I think comes into it is duplication of appointments. This is very similar. Like I said, they were very helpful in the setting up of this, to the appointments they do at the Christie itself. And a lot of our patients do go between the two. So what we don't want to do is for us to see them and do all this, and the Christie girls to do exactly the same. And like I say, our 2 information systems don't talk at the moment, so it's not like they can just go on and say, oh, you saw Rachel last week, what's different now? It doesn't happen. So there's still a bit of work to go on at the moment to work out that that doesn't happen. And then follow-up. So it's a really good appointment. We've had really positive feedback from the patients that we've had through clinic. They felt it was well worth it. But what happens next? The girls at the Christie follow them up after the next CT scan with a phone call to see if anything's changed, if the needs are the same. We haven't got that availability yet, so that's something that needs to be worked on in the future. And like I say, hopefully with new staff, new eyes and new ideas, we might get there. So looking ahead, these are our ideals. All patients with secondary breast cancer, or metastatic breast cancer, I wrote this before I heard your talk, will be offered an appointment, that we'll get better data collection of actually knowing how many patients we've got on our books and where they're up to. That staff involvement across the whole team, but also across the hospital. We're talking with our acute oncology colleagues about patients who are admitted. Clinic and follow-up format will be better. As I said, at the moment, there isn't a follow-up plan in place, but we know that that needs to happen. And then eventually being able to audit and feedback and education. Me and Joe were talking about this earlier, I think, Joe, weren't we, about education, and in particular in some of our ethnic minority areas, which we both cover quite a lot of with between us at the Christie. You can speak to any of my colleagues who are here today. Our numbers, I'm sure everybody else is seeing the same. Our ages are getting younger with breast cancer, and scarily enough, our ages are getting younger with metastatic breast cancer. So there's got to be a change in how we support them and how we look forward for them. And hopefully this is just a whistle-stop tour, and I'm not saying this would work for everybody, but for us, this is how it's working at the moment. And so far, the feedback's been really good. So, thank you.
Thank you, Rachel. So our third speaker of the afternoon is Dr. Sarah Puffer, who's an FY2 from North Manchester General, and she's going to talk about the role of the artificial intelligence in optimising patient recruitment for breast cancer clinical trials.
A very good afternoon to everyone present. My name's Sarah. I'm one of the Foundation Year 2 doctors, and I'm here on behalf of the breast surgery team at North Manchester to talk about our pilot project that we recently undertook on the role of artificial intelligence in optimizing patient recruitment for breast cancer clinical trials. Now, identifying and recruiting patients for breast cancer trials is one of the most time-consuming processes. Presently, patient recruitment is done by a dedicated team, including research nurses and clinical teams. And there are several challenges in this process. It's a very time and resource-intensive process, again, coupled with the lack of sufficient time to do this within clinical hours. there's always the risk of missing out potential candidates, and that means patients are missing out on opportunities. And finally, the risk of delays, especially with complex patient matching. Recently, there has been a lot of growing interest into using artificial intelligence for recruiting patients into clinical trials. And again, this is an area that's actively being researched in recent years. Most of the studies have been mainly focused on either oncology or cardiovascular science. And again, it's been mainly focused on patient selection. Although the use of AI in patient recruitment is still being researched, there are several benefits to using AI. It can help match trial participants with potential clinical trials and provide a list of automated trial recommendations for each patient. Naturally, it can create a very rapid recruitment process. Because you're using less manual labor, it means less people are involved, and that means you can increase efficiency at the various sites. And because patients have increased access to clinical trials, it can help improve the overall patient experience. In 2017, Ancora, a Swiss company, developed an online tool called Ancora, which is an AI-based search tool that was mainly focused towards patients in order to increase their awareness and access to clinical trials. The way Ancora works is it provides patients with all the available data on the latest clinical trials that's available in the public register. It's a tool that's easy to use. You can access it online if you look it up on a search tool, and then all you need is to create a free login account to be able to use it. So once you've identified an area or clinical trial that you're interested in, for example, breast cancer trials, Ancora provides a list of screening questions for which you need to provide the patient information. And once you've done that for your patient, Ancora provides a list of trial recommendations for that patient. So this is just an example of the trial recommendations generated by Ancora for one of our patients. This brings me to the objective of our pilot study, and that was to assess the validity of using Ancora for patient recruitment for breast cancer clinical trials. It was a retrospective pilot study, so we identified breast cancer clinical trials run by the breast surgery unit at North Manchester. We reviewed the MDT list for November 2022 to identify the patients who were eligible for clinical trials. We ran their information through Ancora, and Ancora generated a list of trial recommendations for each of our patients. And then we compared the trial recommendations by Ancora with that of our research team. And these were the main trials that we were particularly interested in. So from the MDT list in November 2022, we found there were 106 patients in the list, of which 50% of the patients were eligible for various trials. We ran their information through Ancora, and this is just showing the patient distribution for the various clinical trials as per Ancora. We then compared the results of the various trial recommendations for our patients done by Ancora with that of the research team, and we found some pretty interesting results. So for one of the trials, Poetic A, Ancora identified 29 patients, whereas the research team identified none. For ATNIC, which is one of the bigger studies, Ancora identified 4 patients, and again, research team also identified 4 patients, but what we found with the 4 patients in the 2 groups were not the same. They were 4 entirely different patients, which was interesting. For Optima, Ancora identified 3 patients compared to the research team who identified 2 patients, and again, when we compared the 2 groups, we found that one of the patients identified by the research team was the same patient picked up by Ancora. For Compulse, again, Ancora identified 15 patients, none were identified by the research team. In addition, Ancora also provided an additional trial recommendation of Ad-Aspirin. And although it's not one of the trials run by the breast surgery unit at North, it is run within the trust, MFT trust. So it was interesting that it was picking it up for 2 of our patients. So to summarize the results, we found that Ancora has the potential to aid the research team in patient selection and recruitment because it can synthesize and analyze large and complex patient data quite quickly and provide the clinical team with a list of trial recommendations for each of our patients. Because it was picking up trials run within the trust, not necessarily within our radar, it can be used to integrate clinical trials within the trust. And from personal experience, it was a very user-friendly software. But we did realize there is a lot of room for optimization in order to reduce that discrepancy we noted between the trial recommendations by Ancora and that of the research team. So as part of the recommendations from our pilot study, we realized we wanted to have a closer look at the screening questions that we used to stratify patients, and then work alongside the developmental team at Ancora to try and see if we can go over some of these questions, fine-tune the questions, and see if it improved the results. If we can sort of further optimize this tool, then we can potentially use it as, again, a complementary tool rather than an absolute tool for patient selection and recruitment. Again, I've highlighted the words complementary tool because, again, we would want to work along with the research nurses to help to improve the accuracy. So a bit of an update. 2 weeks ago, we actually met with a developmental team from Ancora, and we ran over the results of our project with them, and then we suggested some some potential recommendations for the software. So we had some recommendations for introducing some screening questions, and again, fine-tuning some of the questions, including addition of questions on auxiliary node status, which is a really important factor for certain trials like APNIC. We also recommended some changes in the results section. So how Ancora presents a results section is, for every patient, it provides a percentage match for a patient for a clinical trial. So for example, this patient is an 80% match, which isn't really helpful. So we provided the suggestion that Ancora provide a binary response like, yes, this patient is eligible for these trials, and the patient is not eligible for XYZ trials, because that's more helpful for the clinical team. We are having another meeting again later this month to sort of go over the progress with the developmental team on how far they've gotten to developing the software and trying to see if it can help reduce some of the discrepancies that we noted from our pilot study. And that brings me to the end of my presentation. Thank you all for your attention.
Thank you, Sarah. That's really interesting. So next we've got Molly Pipping, who's a Senior Programme Lead for Education from the Greater Manchester Cancer Alliance, and she's going to talk to you about the Greater Manchester Cancer Academy.
Afternoon, everyone. I just wanted to say personally, thank you so much for all taking the time out today to be here. This is the first offering that we've had under the Breast Academy through the Cancer Academy, so lovely to see you all here today. We've heard so much already today about like the innovations and what more we can do for our patients, but ultimately we can only do that for our patients if we have a well-resourced and educated workforce. So my pitch to you today is, when you leave this room, to invest in yourselves as well so you can do more for your patients. So I'd like to think most of you know something about the Cancer Academy. You're all here today, but just so that we're all aware, the Cancer Academy was established to support the development of a sustainable lifelong learning model, and that's for all our workforce, regardless of care setting, to support the current and future needs of our population. So we want to make sure that you're all equipped with the skills and tools necessary to deliver that best patient care. The Academy links to the NHS People Plan, the Long-Term Plan, and the NHS Workforce Plan as well. But one of the beauties of having an academy is that we can reduce the inequity around access to cancer education, and we can standardise those offerings, which should also reduce unwarranted variation in patient care. Everything that we do is driven by workforce need, which I think is quite special to us. Makes us very different. We don't want to teach you what you already know. We want to hear from you, where are the gaps in your education. So we started as a pilot within urology 2 years ago now, and we came up with a model that we felt was quite transferable and nimble. So we've got our website, which is the hive of cancer education. So everything is there, all of these different blended learning offers, from modules, webinars, skills labs, events and podcasts. We've also got an education directory, because we're not precious about what's going on. We know that there's loads of good stuff going on a national basis. So we've quality assured all of that education and signposted it in there for you. And we've also got an e-portfolio, which I'll come on to a little bit later. But I suppose this is how we've grown over the past 2 years, and we've gone from just being that pilot site in urology to 19 other cancer academies, transcending all tumour sites and cancer pathways that we've got at the Cancer Alliance, as well as some other cross-cutting programmes as work, such as personalised care. This is our team. There's some familiar faces here. I'm sure you've all heard from Tilly as well about today's event. But we're a growing team to make sure that we can obviously facilitate the education that's required across all of these sites. The Academy comes under the Workforce and Education programme of work that we have at the Cancer Alliance. So we've got a strategy, and these are some of the points that it aligns to. But really what I wanted to show you is the vast amount of work that goes on behind this. So I think there's 89 different pieces of activity that sit within this across all of the different pathways. As you can see, we've started in breast. Obviously, we're all here today at this event, but we're also doing some other work with the likes of Kate, Anne, and the team at the Christie around the endocrine therapy education as well. But if you do feel like you have any educational needs, then we would really love to hear from you. Please do get in touch with us, because we do have budget to obviously support these initiatives based on what you need. I wanted to shine a light on a few offers that we've currently got at the moment as well, that aren't necessarily breast cancer specific, but might be important to you as part of your career and your patient care. So we have released a module in conjunction with the LGBT Foundation, all around having inclusive conversations, using more empowering terminology. All of this is free at the point of access and sits on the Academy site, all CPD accredited. Something that's really exciting that we're about to launch, hopefully around Christmas time, is using artificial intelligence to bring advanced communication skills training. So this is something that all AHPs and CNSs are required now as part of the National Ascend framework. I'll talk about that more in a second as well. But we know that we don't have enough access to this across the system, and that it can also be very expensive and take up a lot of time as part of those 2 days. So we want to make it more accessible for you. There will be 200 free places on this as part of a pilot. So if anyone is interested, whether you've already got your advanced comms or if you need it, then please get in touch with us and add yourselves to the list, because really interested to see how that one goes. Following on from that, if you need to have your advanced communication skills training, then you're also required to have psychological level 2 training. We know that we don't have enough supervision in place, but equally that doesn't negate the need for people to come on the training in the first instance. We know that we need to do more on that other area as well. But again, we've got a pilot that's out at the moment around psychological level 2, bringing this to you in a hybrid format as opposed to the classical 2-day face-to-face sessions. So if you go to the Academy website, you'll be able to register for this. The session's available in 2024, where you do some online learning and then you come to the classroom-based session. But all of this hinges off the back of the Ascend programme that I mentioned. So this is the Aspirant Cancer Career and Education Development Programme that's come out of NHS England, a multi-professional end-to-end career framework, looking at people from the beginning of their careers at supportive and assistive, all the way through to consultant. The framework has over 400 capabilities in it, but we like to do things a little bit differently in Manchester. So we've taken that generic framework and we're creating specialty-specific variations of it, one for each cancer pathway. Breast is currently in development, and we would love for you to get involved and help us shape that and support it. There's some laminated QR codes on your table, and there's some outside as well. And if you're interested in having a look at what's associated with that, then we'd really appreciate it if you get in touch. It needs to be fit for purpose for you, so we want to make sure that we have your views on it. And we've got some additional ones that are coming next year as well. But I suppose what I wanted to do is really explain what our e-portfolio does. So we know it's all well and good going out and doing all of this CPD, but we all know that we need somewhere to log it, and not having just these paper copies and ESR is a little bit clunky. So we're working with the national team to bring you an e-portfolio, and hopefully the video will summarise it a little bit better than I can. Do we have sound, Tilly?
Introducing the new Greater Manchester Cancer Academy e-portfolio platform. A brand new system designed to support you with your professional development. With the e-portfolio, you'll now be able to log your learning achievements and highlight development opportunities to progress with your career. You'll also be able to have more informed appraisal conversations, as well as support with revalidation. The e-portfolio is centred around the levels of practice in the Ascend framework: supportive, assistive, pre-registration, registration, enhanced, advanced, and consultant. We've also created the speciality-specific frameworks for each cancer pathway. So whatever level you're currently at, you'll have the resources you need to progress in the palm of your hand. Find out more and create your e-portfolio at gmcanceracademy.org.uk.
So that's free to access. Every single person in this room, because you've registered today, you should already have an account available to you. When you log in, your e-portfolio will look something a little bit like this. It will ask you just to select what level of practice you're currently at based against the Ascend framework, and then you can log all of your CPD against that, including today's event, which will make sure is added into the capabilities directory. That's the QR code again, just if anyone wants to scan it in terms of getting involved in the shaping of those frameworks. But I suppose the last thing for me to leave you on, because I couldn't do an educational talk without it, is just mentioning our upcoming Greater Manchester Cancer Conference. This is coming again next May, the 14th and 15th, our 2-day conference with our awards evening in the middle as well. Our flagship event, we're still shaping the agenda, but already looking like it's going to be a fantastic 2 days. So save the date in your diaries. Tickets won't be released until January, but we look forward to seeing plenty of you there as well. But thank you very much.
Thank you, Molly. So our next 2 talks are by Dr. Sasha Howell, who needs no introduction really. He's going to be giving you an update on, on genomic testing and EPROMs in medical breast oncology. Thanks.
Thanks for that. So I won't introduce myself then. Genetic testing in breast cancer. So I've been told to get on with it, so I shall. So germline pathogenic variants, just to make sure we're all on the same page, we're not talking about tumour testing, we're talking about the whole body. So an inheritant variant in a gene protects against cancer. So it's a tumour suppressor gene mutation or a gene that is involved in DNA repair, as commonly is with BRCA1, BRCA2. And the reason that we need to identify these variants, and I've put the top one in red, and this is part of the reason for mainstreaming, is it directly influences treatment, whether it's surgery, radiotherapy sometimes, but also the systemic anti-cancer therapy are all influenced by the determination of a positive germline pathogenic variant. Of course, there's also screening implications, and of course, cancer risk of family members. So the current standards for genomic testing are there in the National Genomic Test Directory. It is enormous, 418-page document. It is dynamic, it changes frequently, but it is directly relevant. And there are 24 cancer syndromes or tumour types with germline pathways. Those are all of them, and there are 5 that are relevant for breast cancer, but I've dashed out a couple of them because they're more for the specialist genetics centre. So R208, 216, and more recently R444.1 that I'm sure you all know and love. So we'll just very quickly talk about those. So why are we mainstreaming? Why is it getting so complex? Why are we asking us in the clinical teams to do everything? Well, I think you'd be well aware that genomic testing is just exploding. The genomic services cannot do it all, and I think it's entirely appropriate for it to be devolved into clinical teams. It doesn't mean that we all have to be super specialist geneticists. They are still there. However, if we don't take part in this, those services will be completely overwhelmed and will collapse. So not all healthcare professionals need to become genomic experts. The workforce will need sufficient up-to-date knowledge of genomics in their field and the skills and confidence, and I think that's really important, the confidence to discern where testing may be relevant for the patients. You need to know how to request it, have the conversations with the patients, their families and carers, and the choices they have and the support that they need. So in terms of mainstreaming genomics in Greater Manchester, as part of the national push to mainstream genomic testing, embed the consent and sampling in secondary care routine pathways, secondary care meaning not GPs rather than secondary breast cancer, and protect the tertiary services. As we've said, it's 208, 216 that are prime ones for identification at the MDTs by nurses, surgeons, oncologists as well. We do some of that when patients are up at our end at the Christie, for example. And the breast pathway team was the first to introduce a toolkit to support the clinical teams, and that's currently being used by multiple other alliances across England as well. So I think it's a pretty good toolkit that we've got. Probably I could have got rid of all of the waffle that I'm going through at the moment and just highlighted this website at the bottom. So if you just type in GM cancer, go to breast, go to genetic testing, that's where it is, okay? And then you can just go through everything at your leisure. The algorithm on the left, I think I've got, there is the algorithm. A lot of you will already be using this. It looks like it's quite busy, but actually if you just follow it along from arrow to box, then you actually get through all of your patients. If you think you've got a complex patient, you pop an email or you do a referral to genetics. But the vast majority of patients who are coming through the clinic can be handled, either they are for genetic testing or they're not. I wanted to just put up the Manchester score, which is the thing that some people have some issues with. If you're worried about the Manchester score, I think just go and have a look at it on the website. Effectively, you just need to sort of follow those instructions to identify whether that patient has a family history. If you've got somebody who doesn't meet the criteria by the age they're diagnosed with their subtype of breast cancer, have a look at that family and then just add up the scores that you get, both the number of patients, relatives that have had cancers before, but also the type of breast cancer that your patient has. The reason that that's important, so if we have a look at the first 600 patients that came through mainstream testing, you can see the importance of the chances of being diagnosed with a pathogenic variant. You've got Manchester score along the bottom. Less than 9 means pretty much nobody else in the family is affected. And then if you've got 20 plus, you must be having at least 2, if not 3 other patients in the family affected by breast cancer. Your chances just start to rocket up exponentially with the increase in Manchester score. So it is a very important. Obviously, it's developed by Gareth Evans, and every time it gets tested, it gets validated. Are you familiar with the toolkit? Again, what I think from the purposes of a power hour where we're rattling through things, just get onto the website, and that is where you're going to get familiar with the toolkit. Not only some very good literature, but also some good genetic testing videos. You've got Claire Garnsey there doing one of those videos. They're very informative, just an easy way of thinking about this relatively basic genetic counselling for patients that we need to become familiar with. Keeping up to date. So the most recent update has changed things again. This can be something that's just a little bit frustrating, and I think perhaps what we need to be doing is putting on the GM Cancer website a sort of what updates have we had recently. We know that germline mutation testing is now for all patients diagnosed with breast cancer under the age of 40. Previously, grade 1 was excluded. Keep watching that space, because the chances of having a mutation with a grade 1 cancer is extremely low, and there are certain geneticists who don't like that one. That may go back. Tumour biology required for TP53 was an error. So there was an error that said you needed triple positive breast cancer. That was just because geneticists didn't know what HER2 3+ meant. And so we've got that changed back so that it's now just HER2 positive under the age of 35. And high-grade DCIS is now classed as a tumour. So don't print them out. Look on the website. The algorithm, I think, is quite useful on the wall, but that's pretty much it. And please do continue to use it. And I just want to touch on R444.1, which is for adjuvant olaparib, because this is a change. Olaparib has been relatively recently approved. It gives an overall survival advantage for patients with germline BRCA1 and 2 mutations, whether ER positive or triple negative, if used for a year in the adjuvant setting. Patients do, however, need to be at high risk of recurrence. And it is a little bit complex. I was assured by Claire that there would be a nice algorithm for me to put up on this slide and take you through. It's not ready yet. And that's because it is a little bit complex to work out when we should be thinking about testing these patients. Triple negative after neoadjuvant chemotherapy, if they've got a PCR, then they're not eligible for olaparib. If they've had surgery first and they're at least T2, then they are. So that you can see that there are some patients who are going to be chosen, if you like, for olaparib after their neoadjuvant treatment. Others, in the adjuvant setting, could be determined in the MDT. And I'm afraid it gets a little bit more complicated with the ER-positive group. Again, if they've had neoadjuvant treatment, then you need to do the CPS plus EG score and get it greater than 3, and that's something that none of us have done before. So there are issues with eligibility for olaparib that we need to crunch through and get out there. Watch this space. The algorithm that we'll devise will be out very soon on the website. I just think we need to take this extremely seriously. This is a life-saving treatment, okay? So there is a survival advantage very early on in follow-up with this treatment. So apologies that we don't have that algorithm. That's the kind of it in a nutshell. So anybody who's got N2 or 3 disease with ER positive, or they've had neoadjuvant and got residual disease with some nodes involved, that'll get you in, okay? So that's really what you need to remember for the ER pos. The triple negatives are a little bit more simple. Okay, so I think that is the end of talk 1. Don't clap. So I am already behind. So any questions? I am going to try and sprint at the end of this one, so you just trip me up. Electronic patient-reported outcomes is something that we've are really quite passionate about at the Christie. I think we do need to be thinking how we can use this around Greater Manchester, but we're not quite there yet. We're fairly Christie-centric at the moment. But what are EPROMs? I've missed off the E. Electronic patient-reported outcome measures. Questionnaires completed electronically by patients that give insight into the physical health, mental health, side effects of treatments, but also quality of life. And this schema, on paper by Bash et al., is pretty straightforward. On the left, you've got the patient, they fill in an electronic questionnaire. It comes into the electronic health record, and I think that is vital, that it is integral to what we're doing on a daily basis. And it either has an acute alert on it, or it's programmed to come in at the time, for example, of a clinic, goes to the clinical team, and then possibly the most important part of this is that it feeds back into that patient's care. There is no point in us asking patients to fill in things that we never read. So it has to come back and be dealt with and lead to a change or a continuation of the patient on that pathway. Why are they important? Well, we know that clinicians underestimate toxicity. You can have these slides. I'm sure they'll be uploaded, so you can have a look at these references. Clinicians underestimate toxicity. EPROMs have been shown to improve quality of life. They've even been shown to improve survival in more than one study. But personally, I think that what we're finding in oncology, and I wasn't here this morning, I don't know whether or not there was a lot of talk about the fact that we are rather busy as a sort of a broad team in Greater Manchester in breast. Ever more cancers, increased treatments, more complex treatments, and longer survival, which is great, but it means that we've just got this huge issue with the workforce, and I think that EPROMs is one way, one small way that we may be able to impact and improve on that. So the Christie approach has been since 2019. It was a large grant of about £2.5 million awarded from the charity, improved communication between patients and the Christie teams, to monitor symptoms remotely and be more focused for our patient care. That's just one of the flyers that patients get about My Christie, My Health, and that's the sort of thing that they see on their phone, just asking them a question. Is obviously what we do all the time, filling in questionnaires on our phones. There are 3 broad parts to EPROMs. One was just to sort of try and get it rolled out in the Christie, and that's fairly successful now. It's rolled out across 19 different tumour types and teams, using it in individual areas that they felt that it would be useful at the Christie. Second and third parts are coming now. They're just coming on board, which is EPROMs to personalised follow-up for patients. And I think that is something that we really could do with adjuvant breast cancer, so early breast cancer in particular, but there's no reason why we can't do it with advanced as well. And then the responsive service is trying to look at whether we can have, you can have a hot and a cold responsive service. Hot is acute toxicity, need help urgently, fill in an EPROM, and it comes up on somebody's screen sitting at the hotline and they get back in touch with you. Cold responsive is patient-initiated follow-up. But it's probably a very good way of managing your workflow. So rather than somebody trying to be on the phone, ringing people back all the time, people not being able to get through, is actually managing it through an EPROM in, text out service. An example of what we've done in terms of our treatment pathways, with the HER2 team, we've got some very interesting data. Now, obviously, you're all aware of Herceptin. When Herceptin came in 2005, this was the pathway. Surgery, chemotherapy, Herceptin for a year, 4 heart scans, easy. This is the pathway now for Herceptin. We have a dedicated, so I think we had half a full-time equivalent in 2005. We now have, I think, 3.5 full-time equivalents. I can't exactly remember. I've taken it off the slide for brevity. But it's incredibly complicated, and the treatments are coming all the time, and the treatments are changing. The data from adjuvant TDM1, for example, is now being superseded by adjuvant Enhertu. It's always changing. So we've got this complexity, more treatments, need more people to manage, unless we make things more efficient. And so what we thought was, let's do a pilot. We'll see whether or not getting electronic patient-reported outcomes for patients when they should be having a phone call to tell them what the result of their heart scan is, see how they're doing with side effects. And so we said, well, let's, instead of doing that telephone call, we'll just send them an EPROM. We'll find out what it looks, what their side effects are. And so it's 12 symptoms about side effects, 6 on quality of life. And felt if the EPROM's okay, the heart scan's okay, we'll just text them and say everything's all right, we're going to carry on. And what we showed with that was that we saved about 2/3 to 3/4 of the time of the phone call. You've still got to do the reviewing of the notes. You've still got to do all of the admin and the letter creation and so on. But in terms of the actual telephone call, even when you take into consideration the time it takes to read through the symptom checklist, it saves about 2/3 of the time. So that was some very interesting data from the HER2 side. I've also put some slides on about adjuvant abemaciclib. I don't know whether Suzanne and Anne might have mentioned a little bit about this morning, so I'll skip through quite quickly, partly because I've got, I think, minus 60 seconds left. But the adjuvant abemaciclib service, so abemaciclib reduces the risk of distant recurrence in high-risk ER-positive, HER2-negative breast cancer. That is on the left. These are the Monarch-E data. The latest one's presented by Steve Johnson. It does, however, have considerable toxicity. On the right-hand side, this is the amount of diarrhea that we get. Patients get, with hopefully not after a Nest lunch. So we've got nearly 75% of patients in the clinical trial had some diarrhea, mostly grade 1, a reasonable portion grade 2, and then it's kind of persisting out to about a year. But this is what we got from the clinical trial. It was approved by NICE in 2022. We kind of saw this coming and thought, how the hell are we going to do this? So we did a joint working initiative with Lilly. Now, Lilly make abemaciclib, but this was not an abemaciclib-specific project. It can't be, because this is how do we improve our complex adjuvant care. So it also included olaparib. It also included pembrolizumab. These big changes that are coming through in our practices. But we did involve all of the relevant stakeholders in the trust, so oncology, nursing, pathology, IT, admin, pharmacy. We all got together and worked out what we thought would be important in developing a service like this for the region. So we were basing it in the Christie, but taking everybody from Greater Manchester, Central and East Cheshire. And our service requirements were a prescribing pharmacy team, the systemic anti-cancer therapy nursing team, who've been brilliant, consultants who haven't, admin support, Bloods Closer to Home, which has been fantastic, and then electronic patient-reported outcomes. 24-question EPROM for every time the patients come through, which is every 2 weeks for 2 months, monthly for 6 months, and then 3 monthly thereafter. Everybody comes so we can eyeball them and consent them at the Christie. So wherever they are around the region, they come. But that is usually the only time they come down to the Christie. And all of the other contacts are telephone or text, unless we need to see them because of clinical reasons. We estimated we'd get 136 patients. That shows you what our data are like. We've got 245 in the first year. So it's been reasonably busy, to say the least, and a very big thanks to the prescribing pharmacists who are here in the audience today. So Chin, Jack, and Suzanne have really been amazing. 102, we've just looked at the data. And of course, what we get with EPROMs is we get data coming back in. Everybody has to complete all the toxicity questionnaires. And the vast majority of patients, the average is 81% completion. So it's looking really nice. And we've seen, I've shown you the graph on the right from the trial. This is the graph on the left that we've just put together from the first 100 patients coming through. And again, you can see we have this persisting grade 1 tox from a diarrhea. It's not quite as high as the trial, but I think we're probably a bit more proactive than the very first trial that was used for this in this indication. But you can see the grade 2 toxicity, which is in the yellow bars, just starting to decline relatively quickly once we get on top of the side effects, dose delays, dose reductions, and so on. And just finally, patient satisfaction with EPROMs is very high. Anything on the left of these graphs is either strongly agree or somewhat agree. So I find it easy to log in, easy to understand, easy to complete. Almost everybody does it on their phone. Most people find it takes less than 5 minutes. Wrong one. And then in terms of other satisfaction measures, I felt involved with my care. So the vast majority of people agree with that, even though they're using something electronic, which I think we sometimes feel is a bit, impersonal. It's part of care. It's not replacing care. It's part of it. And it allowed me to express my concerns. There's free text box, and most of the patients that are going through this put something in the free text as well. So in summary, EPROMs is now integrated into multiple clinical teams at the Christie with appropriate resource. It can improve the efficiency of clinical services. It needs to be resourced. There's got to be someone to read these EPROMs when they come in. And it's been well received by patients and staff. So next needs to become business as usual. We've just had approval to extend this funding. We've still got money in the grant to do the final year of the project. We need to define an appropriate commissioning model to take this forward. We're getting more efficient, seeing more patients. We need to get paid for it. Sorry, I said that a little bit too vehemently. And pilots for responsive service are due to kick off, so looking at how patients can get back in touch with us seamlessly when they're acutely ill. It can still be a phone call, but if people want to do it by EPROM, they can. But also patient-initiated follow-up, and I'm really, really thinking about endocrine therapy, toxicities, and interaction with patients on that line. I think EPROMs would be absolutely perfect. Thank you.
So thank you to all our speakers. Unfortunately, we've run out of time for questions. We've got time for a comfort break. If you can all be back in the room for 3 p.m. prompt, we've got a remote speaker next. Thank you.